And if we love to see faces, so if you choose to turn your camera on, I think, again, we're a small enough group, it shouldn't be a problem with bandwidth. So we'd love to see you. Thanks again, Deborah.
No worries, no worries.
And I believe,
would you like me to? Yeah.
Oh,
hi
Christina,
there,
did
Harriet.
you want to introduce?
Yes. So Deborah Hersh is our virtual happy hour presenter today, coming from Australia. And this virtual happy hour is being put on by the Aphasia and Other Communication Disorders Task Force. And this actually came to us as a topic idea from one of our members, Harriet, who's there on camera, who had knowledge of Deborah's work with this leaving checklist. So we're very excited to hear this presentation, and we hope you all enjoy it. And thank you so much, Deborah, for joining us today.
Thank you. It's an absolute pleasure. I will just move to share screen so that I can show you what I've got. All right. Okay, lovely. Can you all see that okay?
Yes, it's perfect.
Yes. Beautiful. Thank you. All right. So just to kind of give you a little bit of background. So I have been asked to talk about this discharge planning leaving checklist, and I'm very happy to share this with you. So thank you very much for asking me, and thank you, Harriet, for suggesting it. So first of all, I'd just like to acknowledge that I'm speaking to you from Western Australia, but as we try to do here, we acknowledge that we're actually on Whadjuk Noongar country, which is the Aboriginal name for this part of Western Australia. And they're the traditional owners of this land, and I pay my respect to their elders, past, present, and emerging. So what I want to do in this presentation is just set the context for the development of this checklist. I'll talk to you very briefly about some research around the experiences of hospital discharge for people with aphasia, or with stroke and aphasia. And then do a case illustration for you, and then talk about the checklist itself. And with the testing in the new context, really that's around what's happening with Harriet's work in Greece, and also then look at possibilities for this checklist in different contexts, such as in the US. So it's a fairly flexible kind of plan, and I'm very happy to take questions as you wish. So just to set the context, if you take yourselves back a year and a half about now, sort of to early 2020, where we were just getting our heads around this pandemic. I have shown you here a paper that was published around this issue, the COVID pandemic and the impact on care for stroke in Australia. And this paper is based on a registry, a set of registry data coming out of 61 hospitals, but also a survey of another 53 hospitals in Australia. And what they found was that actually over that period where the pandemic was fairly new, is that there was a decline in the number of people presenting to hospital with stroke, probably because of lockdown situation and the fear of going into a public place and so on. At the same time, there was a decrease in stroke unit treatment with 10% reduction in stroke unit beds. And that's because staff were being pulled out into other areas, staff were being redeployed. And the hospitals were under a lot of strain. There was obviously less access for visiting, but interestingly, I've put this here in red, a decreased length of stay, earlier discharge, and fewer patients being discharged to inpatient rehab, and also less information being given to patients. So this paper reports increased discharges without secondary prevention medications, for example, which is a sign that the discussions and the planning was going awry. This screenshot is from April 2020, where the Stroke Foundation here in Australia put out a communication really acknowledging that the pandemic was having a significant effect on best practice stroke treatment in Australia, and reminding the community to really try and maintain standards. They said, for example, that the access to time critical reperfusion was being affected, and that people's access to rehab and care was being affected. So I think there was some disquiet, some upset about the way that this was impacting on people. Now, at the same time as that, so at this time in March 2020, I was the deputy chair of the Australian Aphasia Association. We're a volunteer not-for-profit. And at the time, the chairperson was Linda Worrell, who you will all know if you know the aphasia world. And I was the deputy, and we started receiving messages through our helpline and through comments from clinicians, emails, that they were concerned that the pandemic was impacting perhaps even disproportionately on people with aphasia. There was earlier discharge from hospital, people feeling less prepared for going out into the community, that people with aphasia were concerned because they were unfamiliar with technology, that they needed, particularly in lockdown situations where you couldn't see people face to face and you had to do everything online. And there was a real fear, I think, from clinicians that people would be at even greater risk of isolation than normal. And so we at the AAA, we kind of said, oh, we need to do something about this. And this was very much the context that we were in. So here I've got a couple of examples of some emails that we received in April last year. One speech pathologist in Western Australia. Unfortunately, there's already a trend developing to deprioritize language patients on contact precautions to reduce risk and conserve PPE, which means they're possibly receiving less individual and, of course, no group therapy as in patients. This in turn makes it difficult to advocate for a patient to stay longer than absolutely necessary. And then another comment from Queensland: within our service, due to the closure of outpatient clinics, there's a gap in provision of follow-up services after discharge. So there was, I think, a feeling that, I mean, we know this anyway for anyone who's worked in aphasia, that communication issues are often deprioritized in comparison, say, to swallowing problems, which obviously are higher medical concern. But there was a real feeling that people with aphasia were missing out at this time. What's interesting is that even this year, with the Stroke Foundation here in Australia, with their audit, they highlight that even beyond sort of the crisis of the pandemic, there are still issues around discharge and transition, as you know, which are problematic. So it recognizes that this point is very critical in people's experience and their recovery, that the restriction to visitors during the pandemic has highlighted the need to work more closely with carers and really prepare carers, support them, because they've realized how tricky it is when people are not there as part of the support network when visitors can't come in. But even now, 65% of carers don't get a proper support needs assessment. 64% of carers in this audit, 65 did get a needs assessment, 35 are not getting it. Again, only 64% got relevant training, which suggests that there's still a gap. And 24% didn't get a care plan at discharge. 32% of patients didn't get contact details for post-discharge questions. So there are still concerns even outside the pandemic. And what I also put up here, which I thought was fascinating, is that even in August this year in Western Australia, where we've had a government that's worked very hard to close our borders and keep COVID out. So if I went out now, there's no transmission in the community. At the moment in Western Australia, people are walking around without masks. Obviously in hospitals, there's still PPE, but essentially things are open because there's very, very little, if any, COVID in the community. And even despite that, there's still an impact on our services. So it says here, Western Australian hospital elective surgeries are still being postponed amid severe strain on the system, despite the lack of COVID. So I think that there's a kind of flow-on impact. Just to give you the context in Western Australia, we are under pressure to open our borders to the rest of the country. And so actually for us, things are going to get worse, because once we open up to other states that do have COVID, we're going to have to start doing the wearing of masks outside and that kind of thing that other people are doing. But we've actually had it quite easy. We've had some lockdowns, but not anything like other places have had, but there's still a strain on the system. So I think, we recognize that the discharge issues remain impacted even in this post sort of disaster situation. Now, the reason I was interested in the discharge issue particularly is because I did my PhD around this area, and some years ago, but I was interested in speech pathologists and patient family carer experiences around leaving aphasia therapy. Now, some of that work looked at leaving hospital and the inpatient and acute context, and some of it was around leaving outpatient therapy and leaving community-based therapy. But it was about this notion of transitioning from a support to not having it. And so I've put this up just to highlight that there are papers around that issue now that come out of my research. And that's why when we started getting the calls to the Australian Aphasia Association, why I was so interested in responding to it. If one goes to the general stroke literature, there's some interesting things around discharge and the fact that it's not an equitable situation for all people. So if you have somebody with aphasia coming in post-stroke who had lived alone or who doesn't have a partner, they're more likely to be discharged into, not be discharged back home again. They're more likely after their stroke than someone who's in a partnership or someone who lives with a spouse to go into residential care or some kind of support after their stroke. They're less likely to go home. Equally, rehab experiences and outcomes are affected by a patient's level of social support. So those who have better social support are more likely to be discharged home than those without. And we know that that's really crucial. People with aphasia are very likely to have some erosion of their normal social supports, with aphasia. And a recent review by Chen et al. Shows that hospital to home transitions are still very challenging for people. So partnerships with stroke survivors and caregivers really are needed to improve the discharge preparation and plan. And they say here that these partnerships foster competence to navigate the health and social care systems and to activate self-management capabilities. Without that, things are very problematic. So here it's a hint that the care and the support that we offer at discharge actually allows self-management later on. It's actually really important to help people to then move beyond hospital in a more positive way. I've also published around the experience of being in the acute, the stroke unit acute setting, and made an analogy, if you like, that being in a ward context, an acute stroke ward context, is a little bit like being in transit when you're traveling in an airport. So people are just kind of waiting around for something to happen, as if your plane was delayed. And everyone is rushing around looking very, very busy. And people talk about this, that the nurses rush around, and it's a very, very busy sort of environment. It's not always very conducive to people sitting down and actually explaining and talking to patients, and that they're worried to disturb anyone, just as when you're in an airport, you sit there in a chair waiting for a call for your plane that may have been delayed. People are waiting for something to happen, and often they are bypassed, perhaps is the word, that someone comes in, and does things very quickly, and then they rush off again. And so it's not really an environment that's conducive to good discussion. And finally, on the research situation, we know from work that's been done in the States with you, that aphasia can make these transitions harder, particularly where there are comprehension deficits. And this paper is a really good one. It was saying that aphasia really can impact on discharge, successful discharge interactions, and that particularly where there are comprehension and reading and auditory comprehension problems, the transition is often harder. And we know from working with patients with comprehension difficulty that it takes a little time, it takes more time. You actually have to prepare your materials, sit down and explain things in ways that people can manage. You may need to do that over multiple times to help people to understand and be involved in discussion and involved in decision making. And this paper, interestingly, shows that those deficits are the things that slow things up and make it difficult to include people in discharge discussions. So our case illustration, this, I've changed names, but this is actually based on a true story that came through to us at the AAA. And it illustrates, I think, how the pandemic was impacting on people's services and the interactions that went on. So this was Albert, who was an 84-year-old married man. He's in the UK. And we were told about this because the adult children were here in Australia. He had been living independently. He and his wife lived in their own home. He was out doing his gardening, very active man in his 80s, had a stroke and came into hospital. He had quite a severe stroke, so global aphasia, hemiplegia, and swallowing issues, dysphagia. Now, at that time, the hospital staff really were under strain, so everything that they were doing was in full PPE. In the UK, they were using masks and shields, and everything was very, very difficult. And Albert's wife was finding it hard to visit him. She was obviously elderly as well, but she found the travel through and the lockdown rules and the very restrictive hospital visiting rules, which essentially were, please don't come to hospital to visit your loved ones here. We don't want extra people around. There weren't vaccines around at that time. And that meant that Albert didn't get visits. And as I say, his adult children were in Australia. So everything was done through PPE. And we know that people with aphasia, with global aphasia, are going to find it harder where the person talking to them is wearing a mask as well. And where there are fewer people to talk to and everything is very fast, even worse than normal around them. So the staff admitted to the adult children they were finding it very difficult to communicate with Albert. The speech pathologist really was quite irregular, according to the family, in terms of the number of times the person came in, the speech pathologist came in, and the focus was on Albert's swallowing problems. Nobody really was attending to communicating with him. And as an example of that, it took them 3 weeks to establish that he normally wore glasses. So he couldn't see anything either because nobody had thought to give him his glasses. Ridiculous. In that whole time that he was in hospital, there were only 2 Zoom calls arranged with the staff where they tried to put Albert in touch with his children. He looked very, very frustrated, couldn't really communicate through the iPad. Everyone, you know, was clearly strained. And in the end, he didn't get any rehabilitation. He was discharged to a residential care facility and really was not functioning well. I think even there was PPE and a lot of strain in the residential care as well. And Albert did not have a good experience or a good outcome, actually. But I don't think that is a particularly unusual story during that time. And we probably, if you're working clinically, will have seen similar things. Okay, so that brings us to what I've called rapid response in the development of the checklist. And what I've done is send a PDF of that checklist through to the organisers of this talk, and I'm happy for people to have a copy of that. I've also tried to register this under Creative Commons so people can use it, can adapt it, and I'll talk about some of the adaptations that have happened in a minute. But please acknowledge where it's come from, because we put quite a lot of work into it, and that would be good. And also, I don't want it used in any way commercially, but I'm very happy for people to use it and adapt to their, you know, some of the questions and so on to their context. So we can talk about that afterwards. So here on the side, I've put what the first page looks like, and explained that this is the context, the pandemic. We wanted to try and help structure the interactions and the communication that happens at discharge, particularly for those who live alone, but to make this really available to all staff, not just speech pathologists, anyone who's involved with patients around the time of discharge, to help structure and remind people of the conversations that are needed for a safe, partnership-based, well-informed discharge experience. I came up with this acronym. I was trying to include all the things that from my research and from our experience clinically and also in the AAA that were necessary to make this a more supported and a more useful experience. So just to explain the elements of the LEAVING acronym, very deliberately, I'm glad to say L comes first. I'm a firm believer that we actually need to listen to our patients and hear what their concerns are. So I'm glad that LEAVING starts with an L. It meant that I could put this right up the top. So the first thing is to listen to people's concerns. I think we should be aiming for, you know, a person-centered or family-centered approach, and where possible, that discharge planning should be client-driven, and uses this checklist uses the notion of aphasia as masking competence, but that basically our people with aphasia, unless it's very significant, usually retain a level of competence if the information is given in a sufficiently supported manner. So going back to Gun's work. And so the L is important. We actually need to give people the respect and listen to them and hear what they have to say, rather than being in the airport situation where everyone's rushing around without actually taking the time to interact. The second one, the E, is education. And that's really around providing answers to people's questions, helping to educate them about the process. What do people really need to understand their stroke, secondary prevention or medications? What do their family and friends need to understand what has happened? And closely related to that is to have accessible, so the A is for access, accessible information, so that the information that's given is aphasia-friendly, and that goes for both verbal and written information. And there may be lots of other ways that we can give people that, for example, using videos or through apps and so on. So the education and the information provision are obviously very closely aligned, but the access is also about access to services. It's about access to information, access to the team meetings and so on, that there really is effective communication that goes on around that time. For the V, for validate, we know that when we talk to people with aphasia, we often have to go back and validate that they've understood and that the message that they've received is what we intended. But here I'm extending it actually to validating that they don't just understand, say that they're going into a world where online is increasingly the way that people are communicating, particularly in a COVID situation, but that they've also been able to demonstrate that they can do what we're asking them to do. So here I've put validating, understanding and use of the technology and the media that they need when they go home. And just to give you an example, with the vaccination certificates here in Australia, for example, you get them through an online portal. You have to actually register with a particular health portal and then have that certificate to show that you're vaccinated put onto your phone or onto your iPad or in your computer. Nothing is sent in the post anymore, unless I think you have some request made. So essentially, even to be able to prove vaccination status, you're using technology to be able to book any kind of appointment. Now, all of the banking that people do, their access to social services, these kinds of things are all done through online sources. And so unless we have some way to understand that people can actually use the systems, we know they're going to be isolated and we know that they're going to miss out on services. So the I is around, again, just focusing our questioning on information technology. This acronym is simply a reminder. It's a checklist to help people consider what questions they need to ask the staff, the staff need to ask, but also what issues need to be covered. And with the technology, as we know from the AAC world, where people get, amazing devices, if those devices break down, is there someone around to help mend them? Is there someone to help charge them? How are they used? How can they be maintained? So it's just worth sort of, with these questions, talking to family as well and finding out who's around to help somebody with aphasia manage the technology that we're expecting them to use, particularly, as I say, in a COVID kind of world or a post-COVID world, or anywhere where there's even a potential for lockdown. N is around navigating the system, and we don't always ask these questions, but can the person manage when they go home their health and social care systems? Can they manage bookings? Can they access medications, manage their finances or bureaucracy? And the last one is goals. And it's about asking those questions. What do people want to do when they go home? What are their goals for home practice? Can they manage telehealth? Are they interested in telehealth for their ongoing rehabilitation if necessary? Can they reconnect socially with their friends if they're unable to do that in a face-to-face context? But I think these questions are not only about a COVID context. I think they have relevance now anyway in the 21st century sort of world. This is what I've pulled out some of the sections of the checklist, what it actually looks like. There's a space for comments so people can write stuff down, and there's a very quick yes, no tick box kind of feature as well. So there I've got the main acronym word, listening, with a very basic description. And then, as I say, we've put questions, just simply prompts. There's nothing like you have to use these questions. There's simply examples of prompts, and they can be changed. So things like, we put here, is anything worrying the person about going home? Do they believe they can manage their activities of daily living? Is the person confident about their social supports? Are they anxious about COVID? Do they have any questions? But I've just put these in as prompts. They don't have to be exactly these things. And I think conversations naturally shift into all sorts of areas, and that's just fine. With the education, at the time that I wrote this up, it was really education around COVID. Do they understand what we mean by physical distancing? For example, in Australia, we had changing rules all the time. You could be 1.5 meters from somebody. You had to be 2 meters from somebody. When it was really bad, you had to stay 4 meters from somebody. You know, there was all sorts of changing rules around social and physical distancing. And it would have been very hard for people with aphasia to keep on top of that. Does the person understand their own problem? Do they understand what sort of options there are in their community? Do they understand about rehabilitation and how to get it? Do they understand their medications and so on? Then we had access, we had validation and information technology, and again, just some example questions. Here in Australia, the AAA has leaflets and an aphasia guide, and these little cards. I have aphasia cards, so I've put those in. I've put in under the IT section just some examples. Do you have a computer at home? Do you have a smartphone? Can you manage online shopping? Those kinds of questions come in there, but it's, as I say, it's quite flexible. Navigating the system. This is a good example. So here I've put Medicare, National Disability Insurance Scheme. In the UK, of course, it's under the National Health Service. It's quite different sort of terminology, and it just depends really, you know, where you are and what the terminology is. So that definitely would change according to context. And finally, the goals for the person at discharge. That will change depending on what people want. But for example, we had, you know, can they use home practice or apps and so on when waiting? Sorry about the noise in the background. That's, yes. Okay. The last bit of the checklist is a page that I sort of threw together, colored boxes and a little pathway to try and visualize the transition from hospital up the top to home down the bottom. And with this particular sheet, the idea is that whereas the checklist is held at the hospital with the staff, this sheet goes home with people. It's a reminder for them to have in their hand. And what you would do is put circles around the key things for that person, or you would highlight them, or you could design something like this, specific person by person, to help them think through their particular journey from hospital to home. So for example, if somebody could no longer see themselves, if they were living alone, managing their housework, you might stick a circle around housework and then put in phone numbers of services that they could call for somebody to help them. You might set up the social worker to help them with conversations to establish some kind of home service that they need. Or here we've got a list of things that people might do with their computer or their iPad, so email, Skype, Zoom, you know, different apps. You might have some kind of discussion or ongoing support about those, if that was the thing that the person was concerned about. But either way, this topic sheet is meant to go back with them as a reminder of the kinds of things they've discussed, and for people with aphasia to have something visual that they can then take to their doctor, let's say, and point to the thing that's important to them and so on. So it's a reminder, but it's also a support. Now we put this checklist out to clinicians in Australia and through networks on email, just to see what people wanted and what changes they might like. And we did get some lovely feedback, which we then incorporated into the checklist. But I just put this up just to show, I think, that there was some enthusiasm. Actually, internationally, we had this from people across, not just in Australia, but in the US. So Jamie Azios is very well-known aphasiologist, Sarah Wallace. So from people in the US who were interested and could see that there was some value to this in their own contexts. But also, you know, Ginny here is from the UK, Aoife as well, based in Europe, in London also. I think that there was some enthusiasm for having a resource or a checklist around discharge. Very exciting sort of development with Harriet, who I'm glad is here, could talk about this as well, that at an international online meeting for people involved with support organizations for people with aphasia, I mentioned that we produced our checklist, and Harriet requested that this be translated. She's done a translation with Tatiana Puliaco, who's a PhD student with Harriet, and I'm helping now to co-supervise, has done a lovely translation of the leaving checklist into Greek, because they could see that there was some use for, again, educating staff, reminding them of the interactions, the conversations that really need to happen for a safe discharge. And so this is a good example of adapting the checklist. I'm happy for it to be translated into any language if it's useful for people. But here, what they've cleverly done is managed to retain the acronyms, so to incorporate the messages of listen, educate, make things accessible, you know, validate that people understand and can use what they need to use, information technology, navigating the system, and goal setting. And that all of those things are in there. And what's really lovely is that they've also started to test this out in Greece. And this is from a poster that Tatiana and Harriet have put together, where they were starting to ask people with aphasia about the things that concerned them. And the graphs in the middle show that people felt that they needed assistance, particularly, or see access to technology is a high bar. These are the things that were most concerning their patients that they spoke to and family members. So managing, again, ADLs, knowledge of services in their area, home preparations, but access to technology and goal setting quite high. So I think those discussions are needed really still to allow people to move on successfully and to start to self-manage. So just coming towards the end of this talk, I wanted to just put ideas out about future possibilities. I think arguing about why a checklist like this is useful, and it should be a flexible thing. As I said, the questions can change. I think that the acronym itself actually is robust enough to cover what we need to cover, so that I don't think necessarily should change. But what's incorporated under those parts of the acronym is pretty flexible. But I think that the checklist actually just highlights the need for those discussions to happen at discharge. And as I said, from previously alluding to the some of the literature, the published literature, we know that partnership approaches really do improve the outcomes for people at discharge, but that often they're not happening. And as I said, the stroke audit showed that a third, so up from 65%, a third of people, even outside of pandemic situations, are not getting the care plans and the discussions and a really effective discharge anyway. And that was stroke, and I would say it's probably worse for people with aphasia. We need this because we're in an increasingly online world, and our patients with aphasia particularly are not always very well prepared for that. I think that this, even now that we've got vaccines, we know that there's still some restrictions in hospital settings, and so those discussions may not happen unless we have a reminder like a checklist like this, to sit down with somebody, even if you're still in PPE and rushing around, that they need to talk things through. So I think it's relevant even post-COVID or in a vaccinated context. The checklist is a reminder to ask particular questions around devices, knowledge, support, and so on, and to think about accessibility. It provides a context for increased interactions with family as well, encourages holistic thinking. And I've put here encourages interprofessional attention. And I know that we've got some occupational therapists here. I think these things are really important, not just for speech pathologists, but for anybody who's involved in discharge planning. So social work, nursing, OT, whoever is part of that discharge plan, this should be an accessible kind of tool that might be useful. I think it's useful beyond aphasia and beyond COVID. So, for example, people with English as a second language might find this useful. But with other communication disorders, with hearing loss, there's all sorts of contexts where that extra support for communication is needed. It encourages forward planning, goal setting, and thinking about what is needed prior to discharge to practice for discharge. So getting people to practice on their devices in hospital, and alerts patients to consider how to reconnect, stay in touch, and take advantage of technology. So it's also a reminder for the patients about what they might need. And when they see that final sheet with the little boxes and the little pathway from hospital to home, that's useful for them to think, oh, should I have thought of that? I didn't think of that. Oh, maybe I should be doing that. So it's actually, there's enough there in the sheet that's a reminder for people about what they need to do after leaving hospital. I've just here, for your own interest, put some links to some lovely, lovely resources, particularly the first one from the UK. It's absolutely brilliant, called Getting People with Aphasia Online. And it's essentially a training booklet to help, all done aphasia friendly, full of pictures and beautifully set out text, to help people with aphasia to understand how to be online, how to use technology. It's absolutely brilliant. The other thing we've been doing here at the AAA is running Zoom aphasia groups. And I know that those happen in the US as well, but again, trying to keep people connected through Zoom. And we have in Queensland, Jess Campbell, who is running what's called the Tech Hub. And she does a lot of training for people with aphasia to be online and to use things like Zoom to stay in touch with people, and is hoping to get some funding to run that across the country to access more people with aphasia and to train them, to give them supports to do that. So some nice potential developments there. There's my references. And would just like to open up for questions if people would like to chat further.
Wow, thank you, Deborah. Can I say something really quick and ask a quick question?
Yeah.
First of all, I wanted to mention, as part of the ACRM stroke ISIG, we have task forces that are smaller communities within the ISIG. And obviously, obviously the aphasia task force is the one that that organized this webinar or talk, but we have another task force called Transitions and Continuity Task Force. And frequently we collaborate among the task forces, and that task force is actually looking to hopefully grow its membership and participation. So I just want to make an announcement, if anyone is interested, to please join that task force. But this is fascinating, and I'm really curious personally in it's neat to see it being used in a different setting in Greece. Do you find similar areas are the same, whether it's in Australia and Greece, or are there different areas that people are highlighting? Or do you know yet?
Can I jump in there?
Okay. Yeah, please do, Harriet. This is your area.
Yeah, no, first of all, we are so excited to be on this project, and we want to thank Deborah and the Australian Aphasia Association for letting Tatiana, and I see she's in, so I'm so excited, do this work. Tatiana's in the rehab center all day, 8 hours a day, and she's really finding, and the data she showed you were stroke survivors. It wasn't only aphasia. Aphasia is within that group, and that group is expanding, and we're hoping to standardize the checklist now. Deborah gave us that opportunity. So that's what we're doing. Absolutely. I mean, I've worked in Switzerland, I've worked in Greece, I've worked in Boston, I've worked in New York. I haven't seen any differences anywhere. I just think access to some resources may be a little bit different, and people work in different ways to get that access. But now we're so global, and with telemedicine and everything, and I think Deborah said it beautifully. Discharge planning should be really client driven, and it's not. And I want to add to that, saying that the rehab workforce should be educated in this, and it should be everybody should have the caliber, the skills, the qualifications to be able to understand from their expertise what discharge means, and how to, and adding it to curriculum should be something on everybody's plate in terms of all different programs. A second point is this bridges the gap to life after stroke and life after aphasia, and that whole chapter of life after what goes on. And we recently just anecdotally asked our stroke survivors in our groups, how was your discharge experience and so on, without the leaving checklist, retrospectively looking. And we found really, quite disturbing kinds of information. And I think that is true worldwide. And I don't think we train our clinicians enough, and we're not trained enough sometimes to look at these aspects. So I was so excited with what Deborah has offered, and I want to thank her. And I thank ACRM for also taking her and this information. I think this is a new area that we all need to kind of put our hands into. And like you said, Veronica, there's another part of ACRM, but nevertheless, it should be, it's a triangle, because it involves everybody, and we don't train enough. I don't think we train enough, and we don't know enough to actually look at that chapter. It shouldn't only occur at this. Is that correct, Deborah?
Absolutely. It's really interesting, Harriet, because I suppose, going grey and getting sort of slowly older. But when I started looking at the PhD, and I started my PhD in 1999, I'd already been working 10 years as a speech pathologist, and the PhD came out of exactly those issues. So I'd been working in acute and outpatient and rehab contexts, and I was seeing the discharge point being done very badly. That was crucially important, that people were devastated, around like the lack of control, I suppose, as you transition from one thing to another. And it's in the literature that transition points are points of vulnerability. We know that. And when I started looking at the issue of discharge from aphasia therapy, there was nothing else really published on that in terms of the experience. And so one of the papers that I put out is about training our students. It is exactly that. I was pointing out exactly that we actually haven't focused on this sufficiently in training programs. So that paper goes back to 2010 and got that one out. So it's I absolutely agree with you, but obviously I haven't done enough since then to change the world, but the discharge issue continues to be problematic, and it shouldn't be really. We know that there are things that can be done, and they're very simple. It's around treating people, going client-centered, treating people with respect, and actually spending the time to talk through with them about that journey from hospital to home, or whatever it is, that pathway. What do you need along that pathway to make it work for you? And ultimately, the outcomes are better when you do that.
Yeah.
So.
Yeah, this checklist will definitely be a start. I mean, I know in training, we talk about prognosis for improvement, and we always are telling the patient what the pros and cons are. We don't talk enough about what that whole trend, all these detailed information is in terms of transition, and to the family. And I think that's where our students and basically our rehab services, the workforce in general needs, I don't know, is it an issue that we do not have enough people working within the hospital to take on this topic, or is it such a time? We haven't found, at least just running this checklist, that it's taking up so much time. Tatiana, are you there? You may answer that. But I think, it takes her, after she's done all her therapies, it takes her, it takes her, what does it take you? One afternoon with some patients and you finish the checklist, right? It's not,
maybe less.
Maybe less, right?
Maybe
so
less.
It's wonderful if this gets standardized. At least we standardize it in Greece. You can standardize anywhere, and in Australia and so on. It's great to have.
Yes, and I apologize that life has been so busy. I haven't had a chance to actually research this yet here. We've put it out to informally to the community, speech pathologists and so on, to get feedback. And we, as I say, we incorporated that feedback, but it hasn't been formally tested. And I did apply to my university for ethics to put this through as a project. And then things just got so busy and it never happened. So it's ridiculous, but.
No, but we're doing it here. I hope we have some good results, and they could be, cross-cultural comparisons throughout everywhere, hopefully. So that's, I think, if we can start incorporating it into it also opens the doors for all the survivor organizations, whether it's stroke survivor organizations or, aphasia organizations or any organization. This is really a good bridge, because this is something that organizations can look at and really take on, I think. I don't know what everybody else, feels, but yeah.
Lovely to see you, Jackie. Do you want to hello? Do you want to comment?
Get a lot of questions.
Well, first of all, I just want to say I apologize. I had to be late. I was so sad to have to come late, but thank you so much for doing this. The thing I put in the chat was actually to ask you about feedback from clinicians, which you all were already talking about. So I just think this is so great. And another comment I put in the chat was, having been in a recent experience with a family member in the hospital who had no communication impairment whatsoever and no language difference whatsoever, it needs to be like every patient.
I agree.
Because it's a terrible process when, in all circumstances, really. So it's a huge issue, and I'm so happy you're continuing to do this great work, Deborah. Thank you so much.
Thank you. I've just looked at your chat messages now. I absolutely agree, and I think some of the. By the way, Jackie, I've put the PDF handout of all of the slides available for anyone. So you've got all the points there, even though you missed it at the beginning. It's fine, but the stroke literature also says, so regardless of aphasia, also says that people find the discharge point really hard, and that this kind of support isn't happening for them either. So it's not just an aphasia thing. I absolutely agree. And yes, the feedback we had from people was, please, keep going. Can you change this? Can you add that? And so on. So for example, the yes, no boxes down the side, the red, green boxes, they were not in the original. And somebody said, can you color that? Can you do this colored so it's really obvious? So we put that in. There was another comment about, funnily enough, about the size of the spaces in the checklist for writing things down. I was trying to keep it really kind of tight so that people can carry this just on a couple of pieces of paper if they're doing it that way, or it could possibly go into an iPad as an online checklist at some point in the future. I don't know, whatever's easier. I was thinking paper because then it could be put into medical notes, but now of course medical notes are often electronic as well, and so it can just be used to fit a context. But if it's electronic, it can be expandable. So the idea there is that people can comment on what the person has said or what they might need, and it can just be typed in. So, you know, different suggestions. And I think, as I said, the actual questions within the acronym of leaving, the actual questions themselves can change according to the needs of each individual, the needs of the context. Yeah. So, yeah, I mean, you know, if anyone, as with Tatiana, if people know researchers who have lots of time who'd like to do evaluations, that's great in your own areas, that's fine. I'm going to keep pursuing this here, and we'll see whether it's useful post-COVID. I think Australia, you know, it's not now just a COVID-based issue, even though that's what alerted us to the problem in the first place, the fact that people with aphasia particularly were getting a raw deal at the time of the lockdowns and everything else. So maybe it will continue beyond COVID. Yeah.
There's often resistance to change on new things. You know, here's a lot of extra things you're asking people to do. And then my institution, people often ask about billing things. What do you, for the people that are practicing in the United States, do you see that there's where you could use billing codes for these kind of things as part of your therapy session? You know, you, Dr. Wallace in New Orleans, you, Christina Toro in Chicago area. So some of you all that practice in America, what do you think about that? I'm in Tennessee.
Okay.
Yeah, I can't answer that directly because I'm not practicing now. I'm you know in an academic position, but I mean I could see the issue you're saying, that is it another assessment, right? That then there's a billing for. But I mean, it's not really an assessment. It's more probably really a point of discussion with the patient.
Exactly. Right? I think it should be seen as a prompt, as a reminder for people. They can carry the word leaving in their head, and it's just a reminder. Listen to the person first, educate them. It's all stuff we do already. It's simply a reminder for people to do it. So hopefully it's not something that you have to worry about billing for or whatever. It's actually structuring conversations. It's making sure that people have got something in their hand to take away with them. We forget to give people reminders to take away when they leave, and then they've got nothing to show anybody. And someone with aphasia is not going to be able to report what happened in those discussions. They need something written down. But it's also a reminder, if it goes into the medical notes, that those conversations have been done. And it means that the other members of the team can see that, you know. So
I agree.
I think
it does. I'm sorry.
Go for it, Veronica. Absolutely.
I was just going to say, I totally agree. It seems like a patient education component. And with the way in the United States, hospitals and clinics are really trying to prevent readmission, especially sudden readmission, what a wonderful thing. I would think that we should be encouraged to do things like this to help prevent those readmissions that may occur.
So what comes to mind? Well, first I wanted to thank you for this nice presentation. The fact that you, as Jackie said, systematized everything. You kind of laid out the points that people may hit one or two of them, but not the whole enchilada like you have. And based on what Jeff was saying, I kind of agree. If that's what you were suggesting, Jeff, that might be tricky to put one more thing for people to do on the plate. That might be tricky, but I'm thinking that partnering with other, you know, services like social work, even chaplaincy, because that's what those two services do. They make sure that people can transition smoothly and nicely, and they handle it if they can't. They'll actually walk them through the process. So you might want to look into chaplaincy. People usually, I'm a chaplain. That's why, as well as a speech pathologist. That's why I was thinking of that. So you might want to. They don't generally think of chaplains, and their chaplains are very good listeners. And if they're not usually trained though to work with patients who need special tools, you know, with augmentation for the message. But given that information, they are the best listener ever. we're good
You know,
talkers, good listeners.
I love the fact that you combine the skills of a speech pathologist with the skills of a chaplain. And I think that's ideal. What we need is people who can manage supported conversation, who understand what people with aphasia need, who understand to slow down, to give information with visual supports, to make sure and validate they've understood, all that kind of stuff, and have the time and the empathy of a chaplain. Because that's actually what we need really there. And when I was talking about therapy in transit, my paper around the speed of the acute unit, that's so rare in that context. It's lovely to have that quiet time to sit and say, when you go home from hospital, what do you need? What do you want to do? How are you going to manage this if you're not allowed out of your house because of a lockdown, or even outside of a COVID situation? How are you going to manage this, in this situation, in this context? So yeah, it would be lovely. I mean, this ties in with the literature on communication partner training. We need to do much more to help people who are not speech pathologists to be able to have those conversations with someone with perhaps quite a severe aphasia. So absolutely. Yeah. I mean, I would love to continue to get feedback, perhaps through the ACRN, through your task force, if that's the way to do it, about whether this has potential use in the US, as it has done with Harriet in Greece. And actually, I also wanted to mention, I've been in touch with Marina from Cyprus, and she's also using this over there in your translated form. And it may be, I don't know, in the US, if there are people who are interested, perhaps a Spanish version might be useful, whatever. So I'd be happy to talk to people in the future about making use of this. As I said, it's totally free to use. You can adapt it. My only stipulation is that it's just acknowledged the work that I've done and that the AAA have done to get this out, and also that people don't sell it, just use it. That's absolutely fine by me. So very happy to keep discussing and keep adapting it so that it's clinically useful. Basically, that's the idea. Yeah.
Deborah, do you know Candace Osborne or Marcia Neville? They're in the Texas region, and they're occupational therapists very interested in the transition process.
Okay, no, that's interesting. Funnily enough, I think, has Candace published?
Yes.
I think, yes, I think I do know her name. Yeah, be very happy to meet them. I don't know them. I haven't met them. So
yes.
Yeah.
I was just thinking, I'm going to make sure they at least know that this webinar was recorded, because I think they would be very interested.
Yeah, no, I'm really happy to talk to people about this going forward. And just as Harriet knows, we've discussed this, but I'm very much a qualitative researcher. So the idea of doing, standardizing of checklists and formal, statistically based, psychometrically rigorous things scares me. That's not my bag, really, because not being a quant person, I'd much rather go out and talk to people and do interviews. But if people are interested in, moving this into some kind of evaluation and actually testing it, I'm very, very happy for that to happen and happy to support that. Yeah.
I do want to be mindful of the time. So if people need to log off, but I want to thank Christina for putting this together and making this possible. And Christina, if you have any final words, maybe?
I just, thank you again, Deborah. This was really, really great. And, we do have it recorded, so we will make sure that those who couldn't make it tonight will watch the recording. And, we'll follow up with our task force also, and just kind of say, you are interested in having others, look into the checklist and use it.
And as I say, I've circulated through to you the PDF of the checklist itself. If people do want to adapt it and want a Word document version of it, we can do that. And also the slides, you know, the PDF of the slides, just circulate it if you think people are interested, and that's fine.
Thank you. Thank you so much for all of that.
No worries. It's been lovely to talk to you all, and thank you for the discussion. And Harriet and Tatiana, lovely to see you. And
Thank
we will
you.
catch up and on.
Good
Excited.
morning to you, Deborah.
Thank you, Jeffrey. Nice to meet. Yes, yes, indeed. Indeed, I'm going to have breakfast soon. Lovely to meet you all as well. And Gloria, I know I met you some years ago at an aphasia conference, but lovely to see you. Thank you for clocking in. It's all good.
Yeah.
Thank you very much.
See you later.
Bye.
Thank
Thank
you.
you,
Nice to
everyone.
see you. Bye-bye.
Bye, everybody. Thank you, Kristen.